I'm not a cardiologist, but I'll do the perspective in terms of trying to give you the overview of the cardiology issue. In terms of the MPS, degradation of dermatan sulfate is dependent on multiple enzymes, and you can see MPS 1, 2, 6, and 7 all are involved in dermatan sulfate degradation. It's important to realize that dermatan sulfate plays a crucial role in the valve degeneration, both in non-MPS and more importantly in the MPS patients. This is important not only for the autologous human valve, but also for xenograft, because that's one of the issues that occurs. Dermatan sulfate has a lot of different properties you see here: antisclerotic, immunogenic, inflammatory, apoptosis, proliferative properties. These all are issues that the dermatan sulfate, when it accumulates, causes, and this is one of the challenges in terms of the MPS issue related to the valve disease. As we all appreciate, the dermatan sulfate accumulates in MPS II. This results in substantial thickening, which results in either stenosis or regurgitation of the heart valve. We do see some cardiomyopathy, but it's primarily valve disease that we're concerned about in the MPS II. And in the majority of the MPSs, it's really the valve disease. As a part of this accumulation, we see this early acceleration of degeneration of valves that are really related to the mechanical stress that these valves are under, and all caused by the things we talked about in terms of atherosclerotic, immunogenic, inflammatory mechanisms that all contribute to this degeneration of these valves. In the Hunter outcome survey, you can see that over half of the patients currently have valve disease, and this typically occurs for anywhere from 2 to 10 years of onset. Patients with Hunter syndrome have a lifetime risk almost approaching 100% of cardiac involvement, and this clearly just shows you that all these patients need to be followed by a cardiologist on a regular basis. One of the things that we discovered as part of the Hunter outcome survey is that we saw a percentage of patients who had systemic hypertension. The mechanism is not clear, but you can see here that in terms of looking at the Z-scores, that the majority of the patients are above the mean for blood pressure for their appropriate age, and there's a number of individuals who are greater than 2 standard deviations above. And so it's important to monitor your blood pressure on your patients and treat them like anybody else who may have systemic hypertension, which is unclear how it occurs, but it may be due to abnormal relaxation or flexibility in the blood vessels. This just shows you the nature of the different valves involved. It turns out that, not surprising, the high pressure side, the mitral and aortic valves, are more likely to have problems. You can see more involvement in the mitral aortic, but you still see some mild tricuspid and pulmonary. But the key is really the mitral and aortic valve disease can be significant in this population. This just shows a slide of the left ventricular mass as a function of age. And you can see that some people will consider that the normal left ventricular mass is less than the 50 grams per meter squared. And you can see that there are the number of patients who do have elevated or increased heart size. They also discovered that when you measure ejection fraction is percent of blood the heart pumps at each cycle. And you can see here that the mean tends to be around 50. But for normal individuals, this should be greater than 55. So you can see there's some people who have significant decrease in ejection fractions, and those patients are at greater risk for cardiac issues and clearly need to be monitored closer than other patients. 50% of all the patients do have at age 23 a severe alteration of either mitral or aortic valve. I'm aware of a number of patients in my practice in the US who've actually had 1 or 2 valve replacements because they developed severe congestive heart failure secondary to that. And you can see these cardiac changes can lead to moderate, sometimes a severe left ventricular hypertrophy. They can have ventricular volume overload. They have diastolic dysfunction. All these contribute to arrhythmias. These patients need ongoing cardiology assessments. Most pediatric cardiologists are very comfortable taking care of valve disease since they've seen it with rheumatic fever and other aspects. So even though your cardiologist might not have a lot of experience with MPS II, you should be able to manage the heart disease in these patients and monitor severity by these patients. And it's worth always earlier to find a cardiologist or 1 or 2 in your practice who can see your patients. So Clearly, the cardiac examination is important. It can be difficult because some of these kids are very hyperactive, so it's hard to get sometimes even good physical exams. They don't always hold still. They can have a lot of upper airway noise, which can make hearing, subtle heart murmurs more challenging. It's important to realize that even if you don't have a cardiac murmur, it still doesn't include presence of cardiac disease. So even though you don't hear a murmur, you still need to refer these patients to your cardiologist for monitoring. The key is really echocardiographs and EKGs. They have issues at rhythm. If there's virtually nothing they see on exam, they can come back in a year or two. If they have lots of issues in terms of valve dysfunction or abnormal ejection fraction, they may have to be seen every 6 months. So it's really the cardiologist should dictate how often they get seen based on the severity of clinical disease. One of the last comments is optimal techniques for evaluation of coronary artery disease. Involvement really is unsettled, it's unclear. So recommendations that I alluded to, they should undergo routine physical examination, echocardiograph, and 12-week EKGs at the time of diagnosis. In terms of cardiology, every 1 to 3 years, and I agree with that. So again, in terms of management, it's really standard medical and surgical techniques really can be utilized in these patients. So in summary, the natural history, cardiac findings, and pathology of MPS II, really, there's a lot more to learn about it. And I think what happens is once you have that abnormal valve, that increased mechanical stress, that fibrosis really tends to cause increased deterioration. So what you have is the deposits occur, that causes fibrosis, and then results in dysfunction of that valve. There's really defining specific mutations associated with more severe cardiopathology might improve and refine patient care, but it's not clear if there's any particular mutations that really result in increased cardiac disease.